Hello students, I am Dr. Saurabh Srivastava, reader in the Department of Food Medicine and Radiology, BBD College of Dental Sciences, BBD University, Lucknow. Today we will be discussing the red and white lesions, amongst which the topic of oral lichen planus will be taken up. As we all know that every class will have some learning objectives, so after this class you should be able to classify the disease, identify the lesion which is present, and know the preliminary management of the disease. Now, if we say that this is a lesion, there is certain pathologies which can be said. A precancerous lesion, as said by WHO in 1972, says that it is a morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart, meaning thereby that suppose we have the buccal mucosa in the oral cavity, where the anterior part of the buccal mucosa towards the angle of the mouth or the commissural region, if it has a lesion or a tissue which has some altered appearance, which is not said to be normal, so it is a morphologically altered tissue, and the other tissue or the other areas of the oral cavity appear to be normal, apparently normal, clinically. So if there is some alteration which is seen morphologically in some tissue, it may have more susceptibility towards cancerous changes. This is a precancerous lesion. Examples of which are leukoplakia, erythroplakia, the mucosal changes which are associated with the habit of smoking, carcinoma in situ, Bowen's disease, actinic keratosis, cheilitis, and elastosis. When we talk of condition, a precancerous condition, it will be said as a generalized state or condition which is associated with significantly increased risk for cancer development. That means if we compare with the precancerous lesion, we could see a morphologically altered tissue in the oral cavity. But in the precancerous conditions, we will not see any such tissue which has a morphological state of alteration at a particular site. Instead, whole of the tissue in the oral cavity which will show certain alteration or certain characteristics which are having altered state, and those characteristics themselves have increased predisposition to conversion towards cancerous cells or malignant changes. So then it is called as a precancerous condition. Examples for which are OSMF or oral submucous fibrosis, you all must have gone through in third year, syphilis, sideropenic dysplasia, oral lichen planus, disc keratosis congenita, lupus erythematosus. Now, if there is any change on the oral mucosa or any alteration in the tissue which is clinically visible, so we can assume there has to be certain underlying changes in the tissue which have made it possible to be clinically seen. Okay, based on the tissue characteristics, there is a certain composition which have been given for each type of tissue. Like composition 1 has been given for hyperkeratosis, means increased deposition of keratin in the superficial layers of the mucosa. So we'll see composition 1. Composition 2 will be acanthosis. Acanthosis will be seen in the spinous layer of the epithelium or the mucosa. Then we have composition 3, where the accumulation of fluid either submucosal or within the mucosal cells will be seen, which will give a white color or whitish appearance. Then composition 4 is the presence of microbes, which may be fungal hyphae or the ingress of neutrophils as a result of the invasion into the tissue. The neutrophils will rush towards the site of invasion and give a discolored or whitish appearance to the tissue. So these four compositions, 1, 2, 3 and 4, these four compositions will create a whitish appearance. Then after these four compositions, we have composition 5, which will be seen in cases where the epithelium has thinned out or becomes atrophic. Then composition 6, where there is increased vascularity or vascularization in the epithelium or the mucosa. And composition 7 and 8, where there is some immune pathogenesis or immunological basis is there, and the cells have gathered in the submucosal or the epidermal layers to give this appearance. So composition 5, 6, 7 and 8 are the compositions which may have 5 and 6 will have primarily the reddish appearance, means they will be the reddish lesions. 7 and 8 may be red and white mixed lesions. Then we come to a category of lesions which are broadly classified into lichenoid reactions, means some lesions which are having lichenoid like appearance. These lesions may be oral lichen planus, lichenoid contact reactions, lichenoid drug eruptions, lichenoid reactions of GVHD or graft versus host disease. Now, there may be different etiologies. As we said that these four categories of lesions are appearing like lichenoid reactions, so they may be having different etiologies, but they have a common clinical picture as well as a histopathological picture. So clinically and histopathologically, we cannot differentiate amongst all these unless and until we have a sound correlative history amongst these. Now coming to oral lichen planus, the topic of today, we can say that this disease has been studied since years because Erasmus Wilson has coined this term in 1869, where he found that there a certain appearance of a lesion on the skin or the mucosa which appeared like primitive plants or lichens and which were flat. So lichen planus was the name given to it, and it was associated, or it is said to be, a chronic dermatological disease which also often affects the oral mucosa. So this lichen planus will be seen on the cutaneous aspect as well as the mucosal aspects. The etiology which is said is to be cell-mediated immunologically associated or induced degeneration of the basal cell layer which is present in the epithelium or the mucosa. So we can see that certain cells are there, and these cells, they are infiltrating the epithelium and they are immunologically inducing degeneration of the basal cell layer of the epithelium. What else is present? There is autoreactive T lymphocytes which are present in this component of the tissue, and this leads to the development of oral lichen planus, which is seen as composition 7 as we have discussed in the previous slides. Certain cofactors are also associated with the appearance of this lesion, namely stress being the first and most common, diabetes mellitus, hepatitis C virus, infection is if it is present, trauma, and hypersensitivity to certain drugs. Certain other chemicals and drugs are associated with the presence of oral lichen planus, and we can see immunodeficiency, some genetic factors, psychogenic factors, means stress and other anxiety related psychogenic factors may be associated. Certain habits may be giving the appearance of whitish lesions, and certain other miscellaneous factors may also be associated with lichen planus, not commonly found. Clinically, what will we see in cases of lichen planus? This is very important, as whatever we see clinically is what the patient comes with. So if we know about the features of a particular disease, it will be easy for us to diagnose based on the typical or characteristic features if they are seen. So clinically, we can see a patient who is in the age range of 55, mean age, means 50 to 60 years of age, and females are more commonly associated, or they are having this disease commonly. The sites of this lesion in order of occurrence means most common it is the buccal mucosa, which may be bilateral. So it is very important that bilateral presence of the disease on the buccal mucosa, tongue, lip, gingiva, palate and floor of mouth. This is in order of occurrence, means most commonly on the buccal mucosa and very less or rare on the floor of mouth. Often it is also associated with some pain and discomfort. Discomfort is more common, pain is a little less common unless and until there is an erosive type. We will come to it later. Now the types, as we have said, the types of lichen planus, this is also the classification of the types where this lichen planus disease or oral lichen planus can be classified into reticular type, where multiple thin lines or whitish lines can be seen interlacing amongst each other. That is the reticular type. Then we have the papular type. Papular type is when small dotted appearance of the lesion is present. Thin lines may be present, intermixed may not be present, may be present at the periphery. Then plaque-like, in which we cannot identify the lesion as a separate line or even a papule, but it is present as a plaque is a sheet which is present on the oral mucosa, a whitish sheet like thickened appearance. Then bullous-like, where I think the terminologies in oral medicine have been discussed with you till now, and bullous appearance is the presence of a bleb or bulla over the mucosa or the skin. So it is associated with lichen planus also, when thin fine lines may be seen at the periphery of the lesion. Then erythematous type and ulcerative type are also having a reddish appearance or an appearance of an ulcer in the lesion with thin white lines present at the periphery, which is characteristic of presence of oral lichen planus. Now, the different clinical manifestations of oral lichen planus which is present, it depends upon the magnitude of the subepithelial inflammation. Meaning thereby, if the inflammation is mild, then it may lead to hyperkeratotic type of disease. But if the inflammation is severe, it could have led to atrophy of the epithelium, erosion, or even ulcer formation. So, milder the inflammation, less severe or less symptomatic the disease. Severe the inflammation, more symptoms will be seen in this disease. Then we can talk something about the reticular form, which is the most common form of oral lichen planus, which has slightly elevated whitish lace-like pattern or fine radiating lines which are present on the lesion. There are whitish elevated lesions or papules measuring 0.5 to 1 millimeter in diameter. If we see it in a tabular form with the description of the disease, as we have seen, the reticular form will be slightly elevated white fine lines which are lace-like in pattern, or radiating lines may be seen. These are called as Wickham striae. Then annular lesions are also seen amongst the reticular type, where the ring-shaped lesions are formed and which gradually they become pigmented spots, and the unaffected skin in the center is also seen sometimes. Then we have the atrophic, where the thinning of the mucosa gives a reddish appearance of the epithelium. Bullous is a rare type of lesion, and erosive and ulcerative types are also seen, where the trauma may be associated with the ulceration. Now, this picture of the disease or the lesion can be seen extending all throughout the buccal mucosa. What we see over here is the buccal mucosa, and it can be seen extending all throughout the buccal mucosa with small papules and radiating fine lines which are interlacing amongst each other. Both the things can be seen. These are the papules over here. Over here we can see papules and interlacing, or the white lines can be seen. Some ring can also be seen in this particular lesion. So this type of lesion is said to be the reticular type of lesion. Then we see something else. Now again, we have a similar appearing lesion, but over here the appearance of ring-like lesions is more. So it is having a reticular variety as well as the annular variety of the lesion. Then we have another variety which we have discussed, that we cannot find out lace-like lesions which are interlacing. We can find some ring-like lesions, one ring-like lesion over here, and some slight dot appearance, means small papules can be seen in this part of the lesion. But as we see, the whole chunk or the majority of the lesion, it is plaque type. So we can see that this is a plaque type of lichen planus. On the tongue, we can see that the disease or the lesion is present on the dorsal surface of the tongue with a ring-like lesion on the left side, but a greater homogeneous or plaque-like lesion on the right side. Slight pigmentation may be seen in both the lesions, and some erosion can be seen on one side, on the right side. So this is a mixed type of lesion where lichen planus may manifest in multiple grades. This is another lesion of lichen planus where we can see a plaque present on the tongue or the dorsal surface of the tongue, and erosion is present, and erosion along with certain granular appearing surface is present. This is very susceptible area for biopsy, because oral lichen planus has also got a malignant potential. It can also convert into malignancy. So if there is a certain area of inhomogeneity to the tissue which is surrounding, we have to suspect that area and go for a further investigations confirming presence or absence of malignancy or dysplasia. Then we say that what is seen under the microscope. Under the microscope, in cases of lichen planus or oral lichen planus, commonly in the cutaneous variety, we will see sawtooth rete ridges, which you have studied in third year. Liquefaction degeneration of the basal cell layers will be seen, and a dense subepithelial band of lymphocytes will be seen. So these characteristics will be seen in the oral mucosa also, but sawtooth ridges may not be seen, may also be seen. We can't say. Then these lesions clinically, they are unpredictable. They appear, regress, and then reappear. So they have also been debated to be pre-malignant, as there is conversion rate of 0.4 to 2% into oral squamous cell carcinoma in erosive type of oral lichen planus. So most commonly this malignant change, it is seen on the tongue. And these dysplastic changes which are seen, they are seen mostly on the buccal mucosa. The cutaneous lesions, they are present in approximately 15% of the patients who are having oral lesions also. So whenever we are seeing a patient with oral lichen planus, we have to examine the skin of the patient also. So certain cutaneous lesions can be found on the exposed areas of the skin also. So how do we know the skin lesions of lichen planus? They are pruritic, erythematous to violaceous, means violet in color. Papules, they are slightly raised lesions, 2 to 3 millimeters to 5 millimeters in diameter, and are flat topped. They are not pointed. They are papules which are flat topped, means pressed on the surface, but pruritic lesions are present. There is a phenomenon known as Kovner's phenomenon, which is there is a relief following intense scratching, as that this lesion is pruritic, so scratching will be there for the lesions, and after scratching there will be relief, but this trauma from scratching will aggravate the disease. This is Kovner's phenomenon, which is present on the skin lesions. So this picture will depict the skin lesions which are present on various aspects of the skin, present on the hands, means the wrists, the nails, where scarring of the nails will be seen, oral mucosa, as we have seen in previous pictures also, lichen planus, which is present on the back, on the hands, on the arms. So we can check for the areas, even on the shin of the legs. This is a picture which is showing a flat top papule which is on the wrist of the patient, and the second picture showing multiple papules even on the wrist and the palm of the patient. Scarring of the nails and the lesion pigmentation which is seen on the shin of the lower legs. So the pigmentation is also said to be incontinence of the melanin pigment as the lesion heals. Now there are some syndromes which are associated with lichen planus. like Greenspan syndrome, which is having manifestation of lichen planus, hypertension, and diabetes mellitus. Though it is somewhat debatable nowadays that Greenspan syndrome is no longer an entity, there is Graham-Little syndrome, which is having manifestations of lichen planus, alopecia, and certain nail changes are there. Now, till now, I think that you must be able to differentiate or identify the lesion based on the clinical findings. So we move on to the management of lichen planus. Investigation part usually will involve the blood investigations, because blood investigations may not show anything specific for oral lichen planus, but will be a baseline investigation if we go move on for systemic therapy of giving medicines. So the management will involve the removal of the cause, the medical therapy, surgical therapy, and some other methods which have been tried for management of oral lichen planus. So primarily it is the management which involves the management of the symptoms. So removal of the cause, if we know it is due to a certain cause, we have to particularly remove that cause as it is seen in the lichenoid drug reactions. So we can remove that drug, and the symptoms usually subside. In medical therapy, we usually give steroids, which can be given either in the topical form or in the intralesional form. Then we can give beclomethasone dipropionate spray or triamcinolone acetonide in a gel form or cream base. The regime for the treatment or management in this case will be, if given topically, the topical triamcinolone acetonide will be given 4 times a day for 3 weeks or even more till the symptoms subside. If intralesional injections of triamcinolone acetonide are given, 0.5 to 1.5 ml once per week is to be given for 3 weeks, and usually the symptoms subside in this much time. If prednisolone has to be given, if we are giving the medicines systemically, or patient has to take it and the symptoms are not getting managed by topical treatment, we can go for prednisolone, which is to be given 30 mg per day for first 3 weeks and 15 mg for the next 1 week, then 5 mg for next week. Why this is done? Because prednisolone is one of amongst the corticosteroids, and the corticosteroids have a tendency of HPA axis suppression. Means that when corticosteroids are given externally, the body produces less corticosteroids. So when we stop giving the corticosteroids externally, there becomes an adrenal crisis. If the corticosteroids are abruptly stopped, adrenal crisis develops within the body, which is a state of emergency. Means if we are not giving externally, the body is also not producing steroids, we don't have the efficiency, our body is not having the efficiency to fight or flight. Means we cannot resist the infections or any stresses. Mainly the steroids deal with the stresses of the body. So to overcome or counter this effect, we have to taper the steroids, as you must have studied in your pharmacology lectures. So tapering of these steroids when given for a long time is a must to prevent this crisis. Another regime, with prednisolone, we can give certain adjuvants like the immunomodulator drugs like levamisole, which can reduce the side effect of the steroids or the corticosteroids, where prednisolone is given 5 mg per day with levamisole 50 mg per day for the first 3 days, subsequently followed by 2 to 3 weeks. Okay. We can also prescribe certain antifungals for the superinfection. Means the antifungals which are commonly used are clotrimazole, troches which are used prophylactically. When steroids are used, we can give the antifungals. And vitamin A also can be used, which is given as 0.1% tretinoin cream. and this will maintain the integrity of the epithelium. Some other drugs like immunosuppressants, cyclosporin, which will act on the CD4 T helper cells when either given systemically or topically. But these have their own side effects, and dapsone has also been seen to be used in severe cases of erosive lichen planus. It also has immunomodulatory properties. Then, when these methods fail, or the conventional methods of management of oral lichen planus fail, then we move towards the surgical therapy, surgical removal of the area which is giving the maximum symptoms. Other methods which have been tried are psychotherapy, where the awareness of the psychological aspect of the disease and its management by various psychomodulatory methods of behavior modification has been seen, and it has been seen to give better results. Then PUVA therapy, or the surveillance and high intensity long wave UV light therapy, has also been seen to give good results. Now, to summarize the whole topic of oral lichen planus, we can say that the etiopathogenesis of the disease lies in certain immune mediated cells which are not finding the body cells or the epithelial cells its own. They are acting against its own epithelium or the epithelial cells. So it is increasing the inflammatory response of the body to that area and manifesting itself either in the mild form or in the severe form depending upon the inflammation. Clinically, we can see various types like the reticular form, papillary form, erosive, ulcerative, plaque-like lichen planus. We can see all these forms, annular type, and recognize the disease itself based on the white lines which are present in the disease. There is a certain amount of malignant potential in erosive lichen planus as has been reported. So in cases of oral lichen planus, we have to be cautious and keep the patients under observation, because these patients, when kept under observation, may show sometimes conversion into a malignancy. So if it is early detected, then it is early treated, because malignancies, when the conversion occurs, if the patients prolong it for too long time, or we do not observe the patient at regular intervals, then these malignant changes may increase and the malignant cells may disseminate into the whole body. Then the treatment or the management of the malignancy becomes very, very difficult, and the prognosis of the treatment also becomes very poor. So observation of the disease to check for any changes in the lesion is a must when we find clinically that the disease is present. In management will depend upon the symptoms. Mostly the symptoms are related or directly related towards some discomfort or roughness on the oral mucosa. But we have to see for the cutaneous lesions also, and the symptoms, if present, we have to just have a consultation with a dermatologist, and the cutaneous lesions we can manage with topical applications of corticosteroids, and some immune mediated drugs, immunomodulators, can also be given if systemic therapy has to be tried. So I think that with the end of this session, you must be able to recognize the disease if clinically the patient is seen, know about the disease and its management. Primarily, you can manage the symptoms, and if certain needs arise, then you can refer a specialist. Thank you so much.